Good morning, good afternoon, good evening, everyone, wherever you are. My name is Karen Nahapetyan. I am a Laboratory Technical Officer with the Health Emergency Program at the WHO European region, and it is my pleasure to be co-chairing this very important knowledge sharing webinar along with my colleague from HQ, Natasha. And it's certainly my pleasure to introduce to you our next speaker, Dr. Masab Umair, who is a Senior Scientific Officer and in charge of Virology in the Public Health Laboratory Division, National Institute of Health in Pakistan. Dr. Masab Umair completed his PhD from Quaid-i-Azam University in Pakistan in 2019, and his research was focused on the molecular epidemiology of group A rotaviruses causing gastroenteritis in children below 5 years of age. Currently, he is supervising laboratory activities in the Institute of Public Health in Pakistan related to the diagnosis of viral infectious diseases such as COVID-19, rotaviral gastroenteritis, Crimean Congo hemorrhagic fever, dengue, measles, influenza, and others. In this capacity, he has played a central role in the establishment of the first COVID-19 laboratory in Pakistan at the National Institute of Health, which then became functional on 1st February 2020. Due to Dr. Umair's efforts and technical expertise, National Institute of Health was able to establish a next-generation sequencing facility that played a key role in genomic surveillance of SARS-CoV-2 in Pakistan during the pandemic. He also contributed to development of testing guidelines for COVID-19 and published several articles on genomic diversity of SARS-CoV-2 in international peer-reviewed journals. So Dr. Umair will talk today about the genomic surveillance of SARS-CoV-2 in Pakistan. Dr. Umair, please take the stage.
Bismillahirrahmanirrahim. Thank you again, Dr. Kiran, for the introduction. I'm really grateful to WHO for giving me this opportunity. So today I will just give a brief overview of SARS-CoV-2 genomic surveillance in Pakistan. Okay, so this slide shows the different major activities that were carried out during the pandemic in Pakistan. So Pakistan has a population of 220 million, and it's the fifth most populous country in the world. And so during the 6 waves of COVID-19 that we have experienced, more than 1.5 million cases of COVID-19 have been reported along with 30,000 deaths. If we look at the COVID-19 testing, so COVID-19 testing was started on 1st of February 2020, and it was started at NIH. At that time, very limited facilities were available for testing of the virus. But as the pandemic unfolded and things moved on, so we with the support of provincial health departments and government of Pakistan, we were able to establish more than 200 PCR-based facilities across the country. And in April 2020, a National Command and Operations Center was established under the directions of Prime Minister of Pakistan. To oversee the COVID-19 related activities and efforts carried out in the country. So NCOC was chaired by the Minister of Planning and Development, Pakistan, and it had members from ministries such as the Minister of Health, Secretary Health, as well as counterparts from the military. The main mandate of NCOC was to implement the policies related to COVID-19. So all the data coming from the different provinces was gathered at NCOC, analyzed and interpreted, and the recommendations made at this platform. So NCOC functioned for 2 years, and it ended in April 2022. And now the mandate of NCOC has been handed over to NIH. So NIH is now doing all the work that the previous NCOC was doing. So if we talk about the genomic surveillance, so in Pakistan, the genomic surveillance started in May 2020. but most part of that year, the genomic surveillance was quite low. And if I talk about some of the other activities that happened during the early phase, so one of the strategy was to do the testing, tracing, and quarantine, meaning that testing patients, identifying positive cases and their contacts, and isolating them in order to control the disease. So a lot of focus was done, emphasis was done on this strategy, along with implementation of different non-pharmaceutical interventions, such as use of masks, avoidance of crowded areas, and hand hygiene and physical distancing, etc. So coming back to genomic surveillance, so we established a National Genomic Consortium in May 2021. And a couple of other important activities that were carried out during this time period includes the introduction of COVID-19 vaccination in January 2021. And as of today, 89% of eligible population of Pakistan is fully vaccinated. We also introduced rapid antigen testing at the end of December 2020. And since the third wave, there has been relaxation of different restrictions that were imposed by NCOC across the country. And more recently, it's all about positivity-based non-pharmaceutical interventions. Okay, so coming to the topic of genomic surveillance of SARS-CoV-2. So in Pakistan, just for the information of the audience, we at the start of the pandemic, there was very limited genomics sequencing facility available in Pakistan. And by that, I mean the next generation sequencing facility. So we adopted a dual approach whereby we used the PCR-based commercial kits that had that capacity to detect variants based on certain characteristic mutations. And we coupled that with the whole genome sequencing. So for the identification of the different VOCs, we suspected and tested whenever there was an increase or upsurge in cases based on the surveillance data. We also tested different samples that were that were collected from different geographic areas of the country, as well as travelers returning to Pakistan. At the major points of entries, major airports in the country, there was rapid antigen testing carried out initially, in fact, till the middle of the pandemic. So now it's no more done. So any positive case coming from abroad was tested, quarantined immediately, and the sample was sent to NIH or the provincial lab for further identification of the lineage or variant of the virus. We also look for cases that had severe signs and symptoms, or in a case of high fertility, as well as in case of diagnostic test failure, and for vaccine breakthrough cases. So as I mentioned, we use the PCR-based strategy where we procured real-time PCR kits that can detect different VOCs such as alpha, beta, gamma, delta, and omicron. And these were procured at the national level and distributed to the provincial public health reference labs as well as NIH. And the data generated using these kits was shared with the Ministry of Health, with NCOC, with the health departments, NIH, and other relevant authorities. And although at the start of the pandemic, whole genome sequencing or next generation sequencing was not available in provincial as well as at the federal level, but we had a very established network of partial sequencing or Sanger sequencing facilities across the country. So that facility was initially used to do sequencing of different samples and to find out any variant or so. Data generated using Sanger sequencing was also uploaded on NCBI and GSID. And coming to whole genome sequencing, so we use the strategy of, first of all, this whole genome sequencing facility was established at the national level at NIH and then in some of the provinces. And so the the provinces that had this sequencing facility, they tested a subset of samples and they referred some of the samples to NIH. And the provinces that did not have this facility, they sent the samples to NIH for sequencing. So all the samples that were sequenced, whether at the provincial level or at the federal level, they were uploaded on GSID. And this data was shared with relevant stakeholders in the form of situation reports that I will discuss later on. So as I mentioned previously about the Genomic Consortium, so Pakistan National Genomic Consortium of SARS-CoV-2, it consists of 10 institutes, labs basically, and universities, both from public and private sector. So they are pretty much scattered across the major provinces. Okay, so at NIH, we established this NGS facility just at the start of the pandemic. In fact, fortunately, I was in CDC US back in March 2020, and I was on a training for next generation sequencing. So came back from there, played a small part in establishment of this facility at NIH. So currently we have Illumina NGS platforms such as iSeq, MySeq, and the Oxford Nanopore MinION, as well as the Thermo Fisher Gene Studio platforms. We also have trained staff that is capable of doing the laboratory wet work of next generation sequencing, as well as the downstream bioinformatic analysis. So we are using different softwares such as Genius Prime and in-house pipelines for analysis of the sequences. Okay, this is, so as NIH is the National Public Health Institute of the country, so we develop certain algorithms for the detection of different VOCs based on PCR. So as I mentioned previously, genomic sequencing was a challenge at the start of the pandemic. So we use these tactics to detect and track different VOCs. I will not go into the details, but for people who are working in the lab, they know that SARS-CoV-2 tag path kit from Thermo Fisher Scientific was very effectively used in tracking different variants, especially alpha, the variants that had that 6970 amino acid deletion in the spike gene. So we use that along with certain variant-specific kits for detection and reporting of these VOCs. Just recently, a few months back, we devised a algorithm for detection of Omicron. Again, we use that path kit, and based on the spike gene target failure, we tested those samples for certain mutations that were specific for Omicron. And so the samples were confirmed for the presence of Omicron using this strategy. And in both cases, we always confirmed our samples through sequencing, NGS basically. I would like to share one example of our PCR-based strategy that we use for the detection as well as the timely upsurge of alpha variant in Pakistan. So if you look at the top of the slide, it shows the 6 waves, and the red highlighted is the third wave, which was caused by alpha variant in Pakistan. So if you can see that the cases started rising in March, the first week of March 2021. But our data based on the spike gene target failure showed the cases, detected the cases back in February and in fact in January. And in February, in the mid of February, we were able to report an increase of these spike gene target failure cases. So we shared this data, these findings with NCOC, and I believe it played a very key role, not only in reporting the variant, but it provided timely information for NCOC to take decisions on at the national level. And we have also used the same strategy for detection of Delta variant as well as the Omicron variant. And we were really successful in using this strategy. Okay, so coming to the genomic surveillance, So as I mentioned previously, Pakistan has experienced 6 waves of SARS-CoV-2. If you look at the first and the second wave, very few whole genome sequences were available. And I've told you the reason: because of limited genomic sequencing facility available, lack of bioinformatic infrastructure and resources. So in the first wave, B.1 was the predominant lineage. We also found a G614 variant, which was basically first reported in Europe back in 2020. And this variant, this was in fact the first variant that had the higher transmissibility as compared to the parent strain. So that mutation at amino acid level 614 from aspartic acid to glycine caused this virus to become more infectious and more transmissible. So, but again, since we had very limited sequencing in the first wave, so we were not able to detect much of those cases, but we believe that the first wave, especially the peak of the first wave, was due to that G614 variant. Then in the second wave, B.1.36 was the predominant lineage. And the third wave of COVID-19 in Pakistan was caused by Alpha. We also detected a few cases of Beta and Gamma variant of concern. The fourth wave, which was caused by Delta in Pakistan, and subsequently the fifth and the sixth waves were caused by the Omicron variant. This is just, again, a representation of the different proportion of VOCs detected in Pakistan over the 6 waves. So if you look at the fifth and the sixth wave, so Omicron was the predominant variant, but during the fifth wave, the initial wave was caused by the Omicron subvariant BA.1, which was taken over by BA.2. And the sixth wave, which is the current wave, it is basically caused by the Omicron BA.5.2. So this is just an overview of the distribution of different VOCs during the last 2 waves in Pakistan, that is the fifth and the sixth wave. As I just mentioned, that the fifth wave was caused by the Omicron BA.1. It was very quickly overtaken by BA.2, which was more transmissible variant than the BA.1. Then in the sixth wave, BA.5.2, it took over from BA.2 and spread across the country. We have also detected BA.2.12.1 and BA.4.6. These are the 2 variants we know that have caused high number of infection in US particularly. And just recently, we have identified the first case of Centaurus variant subvariant BA.2.75.2. So although the genomic surveillance, in fact, the COVID-19 testing in Pakistan is on decline, and that has led to decline in genomic surveillance as well. But the fact that this Centaurus is detected in our community, so it's important that we continue doing genomic surveillance. This is just an overview of how the variants, Omicron subvariants, were distributed across the different regions of Pakistan during the fifth wave. So in Punjab, in Sindh, and in Balochistan, BA.1 was the predominant variant during the fifth wave, while in other parts of the country, BA.2 was the dominant subvariant. During the sixth wave, as I mentioned, that 5.2 has been the main cause of infections in Pakistan. So we have also detected other subvariants of Omicron, such as BA.4.6, and as I mentioned, Centaurus and BA.2.12.1 during the sixth wave. So coming to data sharing, I think, which is one of the most important part of genomic surveillance. And so at the national level, at NIH, we have been sharing the data of genomic surveillance with the Ministry of National Health Services Regulation and Coordination. We have shared this data with NCOC, with WHO, country office, and other stakeholders. We not only NIH, but all the provincial labs that were doing whole genome sequencing, they shared the deposited data on public databases such as GCID on regular basis. So at NIH, we prepared a situation report of genomic surveillance, and we uploaded this on NIH website on bi-weekly basis. We also wrote some preprints, especially in case of any unique findings, and we have published some articles. And at NIH, we are also maintaining a next-gen build. So this is the situation report that I was referring to. So we prepared this situation report. It's a comprehensive report on the genomic surveillance carried out in Pakistan. We uploaded on NIH website. If anyone is interested, you can just log on to the site and see it. Again, these are some of the articles related to the genomic surveillance of SARS-CoV-2 and the detection of different variants. Again, if anyone is interested in looking at the different mutations or the phylogenetic analysis, you can read these articles. This is the next-gen build that we are maintaining. Our bioinformatic group of virology is maintaining to see how the virus is evolving in the country. So just to, if I summarize that, genomic surveillance in Pakistan has played a very key role, not only in the timely identification of the different VOCs, but in their tracking. And it has helped the policymakers, such as NCOC, in taking the right decisions. And ultimately, it has helped in the control of the disease. So for way forward, we believe that although genomic sequencing facilities have been established, but it is very important that steps should be taken for the sustainability of such facilities in Pakistan. As we all know, next generation sequencing is an expensive technology, so it's important that these facilities are sustained. One advantage of establishing these facilities now is that we can use them for explanation of the genomic diversity of different infectious pathogens. So, you know, Pakistan is endemic for many pathogens such as Crimean Congo hemorrhagic fever. We have outbreaks of dengue, especially as Pakistan is now going through a flood. So most of the parts of the country, they are affected by the flood. So we have seen increased cases of dengue and malaria and some respiratory infection as well. So we at NIH have used this NGS facility to sequence CCHF, dengue, and I think it has really helped us in knowing the type and the type of different variants for these pathogens circulating in Pakistan. Also, there is a need to establish these NGS facilities in other parts of the countries, especially Balochistan province and AJK and GB regions. And lastly, there is a need to strengthen collaboration with international partners. And lastly, I would like to acknowledge and thank our international partners such as CDC USA, UKHSA, Gates Foundation. They have been, and WHO, country office Pakistan, they have been very supportive throughout the pandemic in helping NIH in establishment of NGS facilities, whether it was providing trainings for wet lab or for bioinformatic analysis, or providing some reagents at time. So I'm really thankful to all of them.